Good afternoon, everybody. Welcome to our webinar, and thank you for joining us. I'm pleased that we're able to have our webinar. Sorry about last month's last-minute cancellation, but we're pleased to see so many folks joining us today. I'm gonna want to first, before we get started, review once again about the webinar. That you are all entering in a muted mode, so we can all kind of listen to the presentation and then wait until really afterward to answer questions. And the ways that we'll answer questions are either by raising your hand with the icon that you see on your screen with the raise hand button, or else typing questions in either the chat box or the question box. I'll be monitoring both of those boxes as we go through the webinar today, and we'll get to those questions afterward, and questions both for the presenter or myself about music and memory. Any questions that you have are certainly welcomed, and we hope that you'll take advantage of the opportunity to ask questions. Want to also let you know, remind you that these webinars are recorded and that we will make them available on our website. So if you've missed one of our webinars, or you've had wish you could let someone else see that webinar or this webinar, they will be available on our website. We've got a page dedicated to the Music and Memory Project, and a list of the webinars and the recordings, and in some cases also some handouts and other information that is at your disposal. So, but do want you to know that we are recording today's as well. I do have a reminder for everyone. We've got quite a few of the quarterly reports in, but not all of them by any means. And so if you've not sent in the quarterly report, please get it to us, and you can send it any way you can get it here. You can send it by fax, you can send it by email, you can send it by regular old-fashioned U.S. postal system mail. And all of those phone numbers and addresses and email addresses are on your screen now, so just get it to us somehow. Because we need that information for our grant. We've got some responsibilities to Kansas Department of Aging Disability to collect some of that data and kind of look at how effective maybe this program is, and could be important for future grants for bringing more facilities into the Music and Memory Program. So today's webinar is going to be on developing sustainable quality improvement systems, and our speaker today is Brenda Groves. She's with a nursing home. She's a nursing home quality project manager with the Great Plains Quality Innovation Network, which is a big mouthful to say and to be. Always get lots of acronyms and things, so I tried to spell it all out as much as I could. But we're really excited to have this as part of our webinar series. As you all know, that one of our side goals, other than just simply wanting to bring the gift of music to as many residents as we could, we're hopeful that here in Kansas, like in other states that have had these programs, that we might see some improvements in the numbers of APs, meds that we're using in our facilities for folks with dementia, as well as improvement in the symptoms of pain and depression. That's why we need your reports back on those measures on a quarterly basis, so that we can kind of track those for your building. And unfortunately, though, across the state, not necessarily in your facilities, but across the state, we've actually seen an increase, somewhat of a slight increase in the number of AP meds, but more telling is that our usage, our percentage compared to the rest of the country, has gotten worse, and so now today we rank as the 50th highest use of AP meds in the country, and being only 50 states, that means we're the worst. So we're hopeful again that we'll be able to point to this as a way that will help folks, and then and as part of that, we want to give you other tools that can help you with that goal of reducing AP meds. And I think this is a good example of a tool that we can provide to do that, to help provide a systematic and sustainable method for your facility to work on goals, including an AP reduction goal that you might have. So it's just a good overall system for quality improvement, and certainly is something you can use for AP reduction. So that's kind of the goal of today's webinar. So I'm going to go ahead and change presenters. Just give us a couple of seconds while we make the switch to Brenda and get her computer hopefully showing here in a couple of seconds. Yep, I can see it. Brenda, again, are you ready to go?
Hi, Barb, can you guys hear me okay?
I can hear you. If anybody else is not able to hear, if you can just let me know in the chat box. But I can hear, so I'm going to assume everyone else can.
Perfect. Well, good afternoon, everyone. I want to thank you all for allowing me to share with you today. I also want to thank you for your continued efforts to improve the care that we're providing across our state to our elders. So thank you for that. Today we're going to be reviewing an evidence-based structured method for decreasing the inappropriate use of antipsychotic medications. The 10-step method was actually designed and developed to provide a sustainable quality improvement system for the nursing homes to be able to track, analyze, and eliminate their off-label use of antipsychotics. This project was funded by CMS through CMP funding and draws from the experiences of a cohort of homes down in Louisiana. A company called B&F Consulting, which you guys may have heard of, but they do support the long-term care improvement world. So if you want more information on them, please let me know. But they put this program together. So there is a booklet, and if any of you guys would like further information on the 10-step method, let me know at the end of this, and I'll be sure to get that to you. The method uses the CASPER data from the quality measure reports to identify the residents receiving the antipsychotics, and then it works to engage staff that are closest to the residents in their daily observation, communication, and problem solving to identify, alleviate, and prevent the causes of the distress through individualized approaches, which, as you guys are working with your music and memory, we're working to individualize our approaches. So this method does align with the principles of QAPI, QAPI, and can be formalized into a performance improvement project. The method includes the following steps here: establishing a leadership team, preparing your team, which is reviewing the guidance and to understand the whys and the how, analyzing and preparing, triaging your staff, or triaging your population, and then your QAPI principles, training of staff, engagement, and then sustainment. So we'll move through some of these sections fairly quickly, which will allow me to spend some time more on the taking action part. Initially, we need to start with a team. The team that's going to coordinate this effort has to include the decision makers, your clinical leaders, and your direct care staff, the staff that are going to be responsible for that daily ADL cares. When identifying your leader, it's really important to make sure that leader has, of course, a clinical role, but that they're able to understand and explain the NDS-CASPER data, and that they're knowledgeable about dementia. This person should be they should be creative. Of course, they need to be engaging so that we can get buy-in from the staff, but they also need to have the authority to implement the interventions. Once you've identified your leader, work to assemble a team that will be able to lead the rollout of this project. Make sure the members of your team have the ability to get the staff buy-in from their peers. We all know that we have those indirect leaders that are on our floor, those CNAs that can usually, that the other CNAs respect. And so they're going to be able to really teach their peers and get the buy-in from their peers. So it's really, really important that we identify those informal leaders and make sure that we get them involved. In the beginning stage, the leadership team needs to begin introducing the change to the staff that are working directly with the residents. And as your team continues to develop the experience and the insight from its initial stage, which we'll get into, you guys will all be ready to fully support spreading it and full staff engagement, which is part of the planned part of your PDSA. And as your bottom bullet here talks, the team, there has to be a line of communication. So you have to be communicating to everyone. So it's really need to have a form of communication instead of just making sure it's always verbally communicated. There needs to be a stable place that's consistent for all communications that anybody can access at any time. Preparing. You must ensure that each team member understands really the hows and the whys of this initiative. I know probably most of you who are on the phone today are aware of the survey guidance documents and the National Partnership to Improve Dementia. I put the training link on here because I think it's an excellent training link. It helps me to understand what the surveyors are being taught and what to look for, and that's what that top link is for. It takes you to the surveyor training, and if you have not visited that site, I highly suggest you do. But again, we need to prepare our staff, prepare our leadership team, that the team that's going to be rolling this out, they have to know why and what's guiding this initiative. The Kansas Partnership, I'm not sure if Barb has shared that with you before, but the Kansas Partnership also has a web page with some excellent resources on there in the hand-in-hand. So I would recommend that if you haven't looked at our Kansas Partnership page that you do that as well and provide those links to your team members to ensure that they have access to that. Once you've developed your team and you've provided that foundation of knowledge for the initiative, the next step is to orient them on the CASPR report. Most of you, again, that are with us today are already very familiar with the MDS process, the CASPR report itself, but the direct care staff that you bring on to your team may not be. Again, it's important that they understand how that coding works, what the timeline is, because we'll be going off of the CASPR to kind of lead you into identifying your target populations. If your team needs further assistance with the CASPR or the quality measures or even for coding, we have resources and tools for that for self-study. Just reach out and I will provide you the links to those. By using the CASPR report in this process, the leadership team has that ongoing mechanism for monitoring your home's antipsychotic medication use without adding in an additional tracking tool. Reviewing the CASPR gives you that target population, like I stated. For those of you who haven't seen the resident level, it's going to mark every resident who was identified on the MDS assessment as receiving either a short stay or a long stay antipsychotic med. The residents who are receiving the antipsychotics that have a diagnosis of schizophrenia, Huntington, and Tourette's are not going to be included on your report. You have residents who have manic depression or bipolar. Even though the medication may be appropriate, it will still count on your quality measures. So it's important to dig down and find the reason for that medication, what that behavior or targeted behavior was, and if it's effective. And we'll get into that as we start triaging our population. And again, one thing I want to note, those quality measure data draws from the MDS, as I stated, so the accuracy is dependent on how accurate we've coded our MDS. Now that you have your list of residents that you're going to put into your antipsychotic reduction program, you need to dig in a little bit deeper. You need to ask yourself some questions. You need to find out more information in this step of the process. And this process can be slightly time-consuming, so we need to make sure that we prep the staff to understand that some of these are not going to be easy. You know, the medications that may have been started on admission, that might be fairly easy. But if they've been on the medication for a couple when they were at home with their family caregiver, was that medication started because they needed sleep, or was it started for caregiver distress? A lot of times when they're at home, the antipsychotic does get started more for caregiver distress than it does for our actual resident with dementia. Was it started because of a geri-psych hospitalization? Are there any other problems? So those are the questions you need to be asking yourself. Was it, like I say, if it was used as a sleep aid, could melatonin be easily substituted for that? We need to dig into that and actually start identifying how we can group our residents. And this is how their evidence broke it down into grouping 1, 2, and 3. So your group 1 should include your coding errors, and then those who you don't have a listed diagnosis. So tracking down that diagnosis, ensuring that it's appropriate, and updating and ensuring that that documentation that supports that diagnosis is all within your chart. Group 2, group your residents who have newly started antipsychotic medications, those who have PRN, antipsychotics, and the residents who are receiving them for sleep. Some of those tend to be maybe a lower burden with a higher benefit of getting rid of them, and so that's our group 2. Our group 3 are those residents that we really need to gain further insight from. We need to look at their history, their patterns, visit with families, maybe even calling and talking to their community doctor to get some insight as to why that medication was started, what the triggers were, and what the goal of the medication was. One thing, we tend to always, especially staff, they tend to focus on the worst case scenario first because that's what we have the most concern with. However, when we start with the harder situations first, it can cause our staff to kind of burn out and not believe in what we're doing. But if we put the harder situations to the last, that allows our staff to build up their experience. And having that experience will help keep them engaged. As I say, early successes are going to build the capacity for our staff to continue their problem solving. As their experience grows in their critical thinking and their understanding of how to resolve these situations that are causing our residents distress, the staff will become more able to take on these more complex situations. They may not be so apt to try the one and done. Well, we tried this intervention and we tried to, do this gradual dose reduction. It wasn't effective, so we can't do it. We need them to understand and assist them with their problem solving. There is a tool, and I will provide this to Barb as well. It was developed by Telligen, which is another QIO, just like Kansas Foundation for Medical Care is. The tool was adapted through a university, and so we did not adapt it and put the KFMC on it, our logo, but it is available on our website. But it is an antipsychotic prioritization tool. It's a very good tool. It helps you break down, once you've identified your target population off of the CASPER and the resident level report, it helps you work through that, identifying which residents may be in group 1, group 2, and group 3. So if you have interest in that, let me know, or you can also Google that tool as the antipsychotic prioritization tool developed by Telligen, and then you'll be able to locate that as well. After you guys have discussed your residents identified on your reports and you've grouped your residents, you need to kind of make that action plan. Give your team 2 to 4 weeks to start working through some of these issues, looking at coding issues, looking at appropriate documentation of diagnosis. Then you need to reconvene your team within a month. Again, you need to be looking at the low-hanging fruits. But we need to be, as your slide states, discussing the status of residents who are still triggering, discuss any GDRs. An appropriate gradual dose reduction could take, 6 months to do it appropriately. So we need to be reviewing those at each of your meetings, reviewing the impact of that. Sharing the new information that's been learned in successful interventions is probably the key that I really want to stress. Once our staff have identified an approach that has been effective, we need to communicate that to all parties involved, not just your focus team that's working on this method, but all staff. They need to, of all units, they need to understand what was successful. So that's where that communication book can come in handy, so staff have the ability to go and review what was effective. We do have some tools here, if you would like, some sheets that mark that you can track on what interventions were successful and what interventions were tried that caused more anxiety or more distress, because we want to stay away from that. Like I say, once we've identified it, and the next staff member shouldn't have to come in and retry it all. For the benefit of our residents, that next staff member should know, what was effective and be able to do that. So again, communication, making sure you communicate that with your families as well, and even the other departments such as housekeeping and dietary. There we go. I went a slide too far. One thing that I wanted to note on this slide before I moved off was that the biggest part, one of these pilot homes noted and shared with us, was that the biggest barrier and the thing that they had to overcome first to get anywhere with this initiative was ultimately changing minds about the use of the antipsychotics. So making sure that you are explaining all of that and supporting your staff, and as the team starts to understand that more and look more carefully at the origins and causes, they're going to have more ability to adapt their approaches. The big question is if we're not able to use antipsychotics, well, what do we do? This is where I want to spend kind of a little bit more time. There is no easy answer, and I wish there was. But just as each of us are different and we all have different preferences and different likes and dislikes, so are our residents. So there is no one cookie cutter approach to providing individualized care. As you guys know, with the music and memory, each of your residents are a little different. There may be, certain components that are the same, and they may share the same genre of music, but their reactions and their responses to those songs are different and they're personal. And so that's how our approaches need to be. So again, we have to slow down. We have to discuss each resident at a time. We need to analyze the potential causes of their distress and the ways of alleviating it one person at a time. It's a multi-step process because, again, once residents are no longer sedated, we're going to have to kind of learn, we're going to have to get to know them again. And so we have to take the time to be able to do that. Staff are going to need time to identify causes of the distress and the interventions. The residents who fought in the shower until the antipsychotics were started and sedated him enough that the shower wasn't an issue again is going to need to be reintegrated and retaught, and a whole new approach from our staff is going to have to be taken when we start, providing those showers again for those residents. We have to understand their background, their personality, their preferences, and their patterns. We must see the world through their eyes and their perspective. It's going to shed light on, what we thought may have been random. So this is a really good time, to reach out to families, ask the staff to share what they've observed, share social history with the staff as long as what you've obtained, the insights you've obtained from families. Make sure that we're sharing those not just with the staff on your team, but with the staff providing the care. Using quick stand-up huddles, we'll talk more about that as well, but that is one important piece that was identified in all of the successful homes throughout this cohort, was the use of the huddles and the learning circles and consistent communication. Often staff who are working with the same residents are able to recognize those early warning signs, and they're able to assist that resident in reducing that distress. They need to be able, to share that. So if they're huddling, they're able to share what's going on, what hasn't worked, what is working, if they need more assistance. One staff member may need to provide additional attention to a specific resident to de-escalate a situation, and so that staff member may need help from another peer member to provide assistance to the other residents on that hallway. So again, teamwork and communication is key to making this work. Tracking and trending. By tracking and trending the behaviors, we're going to be able to identify a potential triggered event before it occurs. So, and we'll, like I said, we'll get into tracking and trending here a little bit further. And again, I can't say enough that we have to form a communication loop with all the staff that are closest to the residents so that they know what is happening and they can take part in this process. The purpose of the education is to explain why and how you're eliminating the off-label use. Again, we've provided training in the beginning with your leadership team to get that buy-in so that they can go out and engage their peers and get buy-in from their staff. But now it's time to train everyone. You need to be training not only, well, all departments, but also invite your families, invite consumers. It's a great way to get community buy-in and community support for your home is to invite the community into your home. So starting by the why. Some of our residents with medications, from being in practice for a while in long-term care, I remember the day when we had to call the residents and their families and kind of sell to them why we wanted the antipsychotic regardless of the potential side effects. And so we kind of ingrained 6-7 years ago that this was appropriate, and now some of us may have to be going back to those same family members and explaining what we know now. So it's very important that we're teaching what the negative effects, that they do more harm, show them the new research, show them that the antipsychotics do more harm without benefit to these residents, that the death ratio and the negative outcomes of using the off-label medications. That is something, with all the training, is something that my organization can help you with as well if you need some further support on that. You know, this is a change in the standard of practice, and it's not going to go away. So as we know, and as Barb mentioned, we are the 50th worst state. So there is a lot of focus on us right now, and the surveyors are focusing on it as well. So again, the more we educate and support of the negative outcomes of that, we'll gain that buy-in a lot faster. We need to understand the perspective of the resident with dementia. This purpose of that training is so our staff can look at it a different way. Maybe look at the situation or the so-called behavior through the eyes of that resident. You know, imagine, you know, how would we act if a stranger tried to come in the middle of the night and wake us up and, you know, turn the lights on and pull us out of bed, or, you know, roll us over to provide pericare when, you know, we would be upset. We would be worried. We would be anxious. Some of us might even fight and become combative. So again, we need to look at our approach when providing care, and so we need to teach the importance of understanding the perspective of the residents. We need to understand what they're communicating. Again, not all behaviors are the same, but what we've learned now is that the behaviors are really just a communication of that unmet need. There's many different types of behaviors that are communicating very, very different messages. So again, we are not going to understand that message unless we understand the person. And of course, it's much easier to change our approach than it is to try to change the way our residents with dementia see things. Tracking and trending, again, share your team's progress so far, share your plan going forward, identify one resident at a time for elimination with staff's involvement. Again, if you go, depending on how your unit is structured, it needs to be very small and structured initiative. So say you are a large facility, 150 beds, and you have various units or hallways or communities within your home. You can possibly do one on each community if you're structured that way. We need to ensure that we can't make too many changes at one time, or the staff are not going to be able to provide us the feedback we need on whether that medication was effective. So if we're selecting one resident at a time, we can train our staff and provide them the tools to be able to monitor that resident, their interactions, their responses, and be able to communicate that back to the team to be able to identify if that dose reduction or discontinuation was appropriate, or if we need to put more personalized interventions in place. They'll give us that idea. But if we do 2 or 3 residents at a time under the supervision of one staff member, they're going to do their best to provide us that information, but it's not going to be as detailed as we need. So again, tracking and trending. In order to understand what that resident is communicating, we need to, again, pay close attention to what's going on, look for those early signs, and document it. With a simple tracking tool, we can note the times of the day, what actually went on, what happened, was there something that precipitated it, what resolved the situation. We can look at those trends to help us understand how to prevent those distress behaviors. One of the examples I pulled here that I thought, was something we see in every home was this man became agitated needing to go to the bathroom. They didn't identify that he needed to go to the bathroom until they trended it, and they saw that pattern. He was having outbursts between 2 and 2:30 every day, and the outbursts kind of varied. It was never too consistent, but when they tracked and identified that it was a specific time frame. So at 1:45, they started trying to engage the resident in different activities, and it wasn't until they were trying to engage him at that 1:45 time frame with different interventions to relieve, decrease that distress, is when they identified it was just a toileting need. Once they identified that and put a toileting plan in place where they were toileting the resident between 1:30 and 2 o'clock every day, his behaviors and that agitation between 2 and 3 decreased. So again, that was one that the behavior, the outburst every day was slightly different, and it had a slightly different trigger, but it was in that frame. And so they were able to take that information and try to make some adaptations, which ultimately were effective. Again, with huddling, huddle each shift, a cross shift, staff check-in about the resident, how the day went, share information, and problem solve together. Again, a whole team effort is really needed. So your housekeepers, your dietary staff, your activity staff, if you're on a skilled unit, your therapy staff, everybody on the team can contribute to what they've observed throughout the day and what their ideas are. You need to, during your training, make sure that you leave plenty of time for the staff to be able to ask questions. Also, some of our staff won't ask questions in a group setting, so make sure the staff know that they can come to you and ask questions if they have further interest. And if they do, if staff are taking the time to come to you privately to inquire more about this initiative, grab them up, add them to your team. That means they're engaged. There's some part of their heart that has an interest for this, and we need to build upon that and make them one of your leaders. Then we need to ensure that we're keeping it at the resident level. So your QI, or quality improvement efforts, closest to the residents, brings the process for that elimination to the point of care. It uses the information that we've gathered and the information that we're going to share among staff at the point of service. For, again, problem solving at the earliest signs of distress. That is kind of our goal, is knowing our residents enough that we can identify distress before it becomes a negative issue for the resident. Going right to that source builds the abilities of our staff. It prevents the distress from the resident, and it also, encourages that team building here, and it makes that staff member feel more like their voice is being heard. A lot of times we hear our staff don't report things because they don't think they're being listened to. So if we make it a point to keep our QI efforts directly at the resident level and including all staff at that resident level who provide daily care, we will gain their insight and their support much faster. One important thing we need to do here with this part is when we bring in the care planning. So as you identify sources of distress and the changes to your approach, if the approach that was successful varies from what is in the care plan, that needs to be communicated. It needs to be incorporated within the care plan. Again, the care plan is what is supposed to direct our care. So even though the surveyors may see that being done, it needs to be on that care plan. So we need to ensure that all successful interventions are being placed on that care plan. So we need consistent follow-up, bringing that information, of course, back to your team meetings so that can be shared and updated. Also, make changes on the spot if you've identified something that works wonderfully. Put it on the CNA assignment sheet, put it on the Cardex, communication book, whatever your method is for ensuring that all team members have been notified, make sure it gets there. QI closest to the resident, though, is not effective unless you have stable or consistent staffing. When the same staff are working with that resident, again, that's how the relationships are built. That's how we can establish trust and be able to identify certain patterns and really individualize their care. As you begin taking on the more challenging situations where the behaviors seem more random, the first step is to activate a charting process to look for those patterns and triggers so that the behaviors can be better understood. I think we kind of touched base on that a little bit. Again, huddles. Every shift, every event, every week, every department. You know, I would like to know if you guys do put in chat if you guys are using huddles. I'm just kind of curious as to how many homes are using this approach to get staff buy-in and for communication. So we're going to, learn by a doing approach so we can develop skills in our staff, help them analyze the causes and. Oh, can you guys still hear me?
I think so. I can.
Okay, I have an echo that just went back on my end, so it caught me off guard. Okay. Again, we need to help our staff learn what and share, what information is important to be shared within one of these huddles. Huddles are meant to be very quick and to the point. That's why they're called a huddle and not a town meeting. So we need to be able to our staff to know what information is there. The Team Steps long-term care model has great communication models that you can use to train your staff. Again, that is something that our teams here at KFMC and Great Plains can assist you with. We have 4 master trainers within our staff. So we can help you with that. Engaging your stakeholders. Really an important part. As we've been working through the initiative, through the partnership, and as we've been working with homes, with their medical director, the biggest barriers that we hear. So you need to make sure that you're including them in your efforts. Your medical director needs to understand what your policies and procedures are, and you need to work together as a team, and then your medical director can guide those other attending physicians. So if you have buy-in from your medical director on this initiative and reducing antipsychotic medications, but you're struggling with your attending physicians and your house doctors, you might have your medical director work with them. We have some homes across the state who have processes in place where the medical director does oversee attending physicians, and that there's reports that go to the medical director on which doctors are prescribing antipsychotics, and so some homes are trending that information and providing it. And that's a good way of kind of giving that extra push to those outside physicians to kind of get their buy-in as well. A lot of our doctors, of course, don't like us to kind of tell them what's right and what's wrong. So by utilizing that medical director, sometimes you can overcome that barrier. Same thing with your pharmacist, really ensuring that your pharmacist understands what it is you're trying to do, what the goal of this initiative is, and that they have that foundational knowledge, like I talked about in the beginning, of the hows and the whys, how it's surveyed, what the requirements are, so that they can be held to a level of accountability as well. Hosting a collaborative meeting, do a meet and greet. Bring in some food or host a luncheon and bring your stakeholders together, and that includes your families, even some, your staff who are really interested, bringing them all together for the one common purpose. When I'm talking here about continuous communication, is sharing your data. As you're trending and tracking your decrease, if you've had an increase of antipsychotic medication use, report it. If you've had a decrease, celebrate it. When you've seen that increase, was that increase directly related to admissions who came in, or are they hospice residents that the hospice came in and ordered? What was the origin of that medication? And share that with your stakeholders. Let them know that this is important to you and that you're monitoring it. And again, don't just celebrate successes, but also share your negatives as well. They need to know what's going on. And your family members. I know I talked earlier about getting buy-in from your families and using them to get history, but they really are a vital member of our improvement team. Some homes who are working on the antipsychotic reduction initiative are looking at their environment, and so when you're looking at your environment, they bring family members in because you're not drilling down on resident-specific information, so you don't have HIPAA violations there. So bring a family member in and assess your environment. What does your family member think? Is there extra call lights at certain times of the day? Is there, do they come in and see, is it loud when they come in? Does it cause anxiety for them to sit in the dining room during meals because of the hustle and bustle? What do they observe in the environment that we can potentially change to decrease that external stimuli? Family members are excellent for that. Plus, that gets them engaged. It makes them feel like they're an important part of your team, which they are, and we need that. Establishing your processes for information gathering at the time of the admit, whether you have a specific questionnaire that you review with the family. I know our social workers have a social history, but there are tools out there to dig in a little bit deeper into their mental health or their history of depression before any of these medications were started, and we kind of need to know that. Some residents, may have been battling depression for many, many years, and this may not be something that will ever really go away. And we need to know that. That needs to be care planned and part of their history, and it allows us to be able to make, hopefully, the right choices in how we're approaching their care if we can really, truly understand what their life is consisted of. And again, providing education to family members about your non-pharmacological interventions, the negative impacts of the antipsychotic drug use, the increased continence, the decreased mobility, the increased risk of death. I mean, they need to know that. But they also need to be educated on ways to relieve that distress, because the family may be in there. They could become one of our best support persons, because they may, if we teach them appropriate ways of helping to decrease anxiety and agitation, they may be able to support us in that initiative. If the family member's there and we're busy and they start seeing the resident kind of their anxiety escalating, they may be able to put interventions in place for us to help de-escalate that, whether it's our music, aromatherapy, decreasing sunlight or increasing sunlight. You know, there's a lot of things that we can do. It just depends on, of course, our person, our resident. Policy and procedure review, you know, I'm down here at the end, and you really should be looking at it in the beginning, but again, you need to, at first it's more important to really understand what's going on, but you need to make sure that if you've updated a policy, you've changed that. I know we have some homes here in Kansas that have changed their policies, that any antipsychotic orders that have to be approved by the director of nursing. The pharmacy cannot fill those until the director of nursing is given approval. So there's other ways. There's lots of ways of kind of setting your policies and procedures up to be effective for what your team needs are. I know if you're on the call today and you have policies and procedures that you'd be willing to share with your peers, you guys may have already talked about this, but chat it in or let Barb or myself know, and we can help disseminate that and get that out there. A lot of times, you know, ban the use of PRNs. We have some homes like that they don't use any PRN medications as well. If they get it, it's a short term, maybe a 3-day order, and then discontinuing it and needing a reassessment before any more medication is sent back out. So again, there's lots of different varying policies that are all been effective for these homes that we can share. And then I want to make sure I have some time for some questions. Looks like we still have about 15 minutes. But sustaining and spreading really is just making sure that we keep at it. Don't kind of give up. Once we've identified what's working, so we want to sustain those improvements, whether that is for one resident or for whether that's, you know, each unit, however we rolled out this project. We want to sustain that. Once we've sustained that, you've usually garnered enough buy-in from your staff that you can spread that out. And that, again, depends on your home and the setup of your home. You don't want to go and spread it across the whole building if you only did your pilot testing on one small portion. But you can spread it from a unit to a unit or a neighborhood to a neighborhood. So if you started on, you know, you did one resident per neighborhood, and then maybe you spread in one neighborhood at a time, so again that you can monitor and track the effectiveness of that. We have lots of tools when it comes on how that team setup should be for reviewing your CASPER monthly. Communication tools, again. One thing I want to, you know, I mentioned on here is don't call and send a Jerry Psych unless absolutely necessary. I think most of you are on the phone have had the same experience that I've had. They usually go to Jerry Psych and come back with more medications than what we sent them with and more sedated than what we sent them. And so it causes a little bit more work on our end once we've done that. I'm not saying it's not appropriate, but we just need to make sure it's absolutely necessary and that we've done everything we can. Again, continuous QAPI processes, continuous PDSA. It's not a one-and-done project. We're going to have to learn with each step we take will be a learning. So, you know, the continued plan, do, study, act is a continuous cycle of quality improvement. One thing I do want to say here is that the ongoing leadership support and communication is ultimately the key to success. Maintain a watch list and use daily rounding and quick huddles, again, to monitor for these residents. When staff are making adjustments to accommodate that routine, follow up. Thank your staff for communicating that. Thank you for identifying that. And again, support them through that. So if that means possibly changing some of their workload or switching things around a little bit so they can provide that little, 10 to 15 minutes more one-on-one with a specific resident, then you need to do so. So continued support and consistent support from the whole care team is what's going to give your staff the ability to adapt and provide better care for our residents. And that's what I have for you today. Again, if there's anything that I've mentioned that you would like further information on, or some support or some self-training tools, please let me know, or Barb, and she can get to me, and we would be more than happy to assist you. For any of you on the phone who have not worked with us or are not currently working with us at the moment, our services, resources, and tools are all free of charge. We are CMS funded to provide you the support and resources that you need. So there is no cost associated.
Okay. Thank you, Brenda. I think that's a really important part, and something that I certainly wanted to bring home is the importance of using your organization for information. You guys have got a lot of really, really great tools, some of which you talked about today. And any of those that you want us to put on our website with this webinar, Brenda, I'm happy to do that. So be happy to be thrilled to have some of those resources to add to the webinar.
Yeah, I think I'll send over, we have a sample PDSA cycle and a performance improvement plan that we've been using in our antipsychotic work group. We have a small affinity work group. And I'll send that over, Barb, for you to put up, as well as that tool from Telegen. That tool from Telegen it's very easy to follow, it's structured, and it's being used in almost every state. It's a really good, and it's a nationally supported tool.
Yeah, that sounds like something I'd like to see. So I'd like to, if you'd send that would be great. And we can obviously share it with the rest of the group then. I really I want to make sure folks know that we do have some time for questions. And so please, if you have any questions about today's webinar, about your Music and Memory Project, anything we can do to help, please ask in the question box or in the chat box, either one. And we'll have a few minutes to get to those. And one of the things I think I really appreciated as an ombudsman is your comments about engaging families. You made that at several different points. And I think that's important for just so many reasons. We wind up involved when the relationships with the families have really kind of deteriorated to a kind of almost an unmanageable place. But I just really think the more that we can involve families up front from the get-go in a positive way, the less likely that is to happen, and in the long run is better for the resident, better for you, saves time and energy and grief, and it's just better all the way around. Family members really need to understand what their role is now, and it's very confusing and very upsetting to them, depending on what their role was before, obviously. But and sometimes I think we have a tendency to say, we got this now. Don't worry about it. Just come and visit, and whatever. Enjoy cookies and milk in the afternoon or something. But families want more than that usually, and it's important for residents to have that as well. So appreciated that.
Sad part too, and one thing I didn't mention but I've seen, is some of our family members don't understand what dementia, Alzheimer's, and the various, there's different types of dementia, and they all present in different ways. So, if they're having hallucinations, but they're, the positive, hallucinations, they're talking, families may not understand, and it may make them uncomfortable, so they may leave. By them not visiting very often because of their own personal being uncomfortable,
right,
that ultimately has a negative impact. Our residents may not know who that family is, but they're going to fill that void. So by supporting our families to understand and what to look for and what's normal part of, Lewy body dementia, or what's the normal part, of Alzheimer's, and what to expect, and here's ways that, if If mom says she needs to go get the kids off the bus, here's things that you can do to help alleviate that. And so that the family feels more comfortable to work through those issues and stay and visit with mom or dad.
Yeah.
We don't want the families to leave because they're uncomfortable and they don't know how to address the situation, because that has a negative impact on all of us.
Absolutely, absolutely. We do have one question, Brenda. We've got a question asking about the Casper reports and that material. And if I remember correctly, you said you did have a document about that. Is that correct? You've got a resource that we could send to that attendee, or do I misunderstand that?
Yeah, which portion of the Casper? On the coding or we have different components. So if they want to email me, and
Okay.
if they don't want to say exactly what it is they need,
Okay.
but yes, I do. On our website, we have some pre-recorded self-study videos on how to code the NDS and kind of how to work through that. The AP one is a little bit more self-explanatory than some of the others, but like the pain and falls and all of those others. But we have all of those out there. But we also have we have various tools like on how to read Casper, how to pull it down, the exclusions, how all of that is built in.
Okay.
And we can provide that support.
Okay. So I'm going to direct them to your email address, which we're seeing on the screen, and they can get that kind of hone in on what that exactly is they're looking for.
Now
you just went away.
Let me go back.
There you are.
Yes, I am going to put it in chat because it looks like they combined my communications folks.
That's not right.
That email is so.
Okay.
It's actually brenda.groves, and then the rest of it at area.a-a. The rest of it is correct. It's just brenda.groves.
Okay.
At a.h.
Okay. You got a couple of different email addresses, so I didn't know which one.
Yep.
Yeah.
Yeah, and it looks like they combined them because my KFMC one is the bgroves at kfmc.org.
Okay.
So I put both those, I put them private, sorry. I will send to, it doesn't look like I have an opportunity to send it.
Well, I can do it here.
Okay.
Paste.
And then my direct line, which is not on here for those who want to write this down, is 785-271-4150. And that would ring directly to my office and voicemail. But we have lots of expertise within KFMC who will be able to provide some support to you depending on what your needs are. And again, I know I'm here talking about the antipsychotics and music and memory, but we can provide you support in various ways on multiple topics. So, and again, our resources are free. I am looking to be putting together the Team Steps long-term care communication model is part of our contract for us to be providing education, so we will be looking at that as well. But if your home would like some private trainings, just reach out and let us know.
Wonderful. It's a great opportunity. Appreciate that. I'm not seeing any other questions coming up, so I guess I kind of want to maybe talk about a couple of things. One, again, remind you to get your quarterly report into me if we don't have it already. Quick change presenters here a second and show my screen. Again, as always, if you have any questions about the project, you see my email address on the screen. Also, the website for our Music and Memory webpage on our website. That's where you'll find this webinar here in a week or so and all the other webinars that we've had so far this year. We've also got our webpage there for finding your regional ombudsman if you have issues or concerns that you need to talk with them about. And then the Music and Memories website as well. One of the things I will say is that I know, my folks are make regular visits to your facilities, and I've heard several stories that are really wonderful stories about the fine work that you're doing with music and memory in your facilities, and we're so happy that's happening, and know that this is just a great benefit to your residents. So I want to thank you for that. I have about 1 minute left, so if I see no more questions, going once, going twice. So thank you again all for coming. Thank you very much, Brenda, for your time today and for sharing about your resources that are also available to help folks with their facilities. So thank you all, and have a wonderful rest of your afternoon and a great week.
Thanks.